Few questions to start off the afternoon. Which of the following is a characteristic of class 3 antiarrhythmic drug agents? They slow impulse conduction velocity and exhibit reverse use-dependent effects. They prolong the refractory period and exhibit use-dependent effects. They slow conduction velocity and exhibit use-dependent effects. Or they prolong refractoriness and exhibit reverse use-dependent effects. So A and C both have conduction velocity slowing, and it's reverse use dependence versus use dependent. And B and D are refractory issues and then also use and reverse dependent effects. Okay? Pretty good consensus that it might be a refractoriness issue. Yeah. Question 2, which of the following is effective for treating PMVT occurring in the setting of triggered activity and delayed after depolarizations? Which is effective? Isoproterenol, temporary cardiac pacing, calcium or beta blockade, or sodium bicarb? Which is effective for triggered activity and delayed after depolarizations? Okay. And number 3, a patient develops symptomatic bradycardia immediately after initiation of propafenone for PAF. The mechanism is most likely unmasking of sinus node dysfunction, slow metabolism due to a CYP3A4 genotype with elevated drug levels, rapid metabolism due to a CYP2D6 genotype to beta blocker analog, or increased levels of propafenone and 5-hydroxypropafenone due to slow metabolizer CYP2D6 genotype. Okay. What is the most appropriate antiarrhythmic drug for a 57-year-old female with cirrhosis and PAF, but no structural heart disease and normal renal function? So Siva Milpru is back to talk to us about the complex issues of all these antiarrhythmic drug agents and some of their important drug-drug interactions, which are very testable things. So Siva, thank you.
Thank you, Steve. So 2 learning objectives. One is to classify antiarrhythmic drugs based on mechanism of action. And the next one is how to choose antiarrhythmic drug for the right patient. So I've kind of divided this into several segments. We will spend a significant amount of time on looking at the action potential and classification of antiarrhythmic drugs. We will explore the concepts of proarrhythmia, concepts of use dependence and reverse use dependence. In the end, we'll look at metabolism of these drugs and how drug interactions can alter the way you use these medications. So we'll look at patient profiles for these antiarrhythmic drugs towards the end of the talk. So now, looking at the classification of antiarrhythmic drugs. So we have to go back to the action potential to understand how we can classify these drugs. If you look at this picture, most of the sodium is extracellular while potassium is intracellular. And when we play this animation, you will see a change in voltage per time. That's the action potential. And over the right bottom corner, you will see the movement of currents across the cell membrane. So the currents that go inside the cell will be depicted below the line. The ones that come outside are going to be depicted above the line. So the resting membrane potential is around 90 millivolts. And during phase 0, sodium comes in, that's depolarization. Phase 1 is transient potassium outgoing. Then phase 2 is calcium coming in, which is balanced by potassium going out. That's the plateau part. And repolarization happens in phase 3, where the potassium leaves the cell. And this happens again and again and again. So when you see this at a cellular level, at the organ level, phase 0 or depolarization is going to be the QRS. Phase 2 is your ST segment. Phase 3 is your T wave. Okay? And the depolarization happens in a very short period. You can see that the phase 0 happens in a very short time, whereas repolarization happens over a long period of time. One critical concept to understand is, as your heart rates increase, the repolarization time decreases. So drugs that act on the potassium channels may be less effective at faster heart rate just due to the fact that repolarization shortens. Whereas the ones that act on the sodium channels, whether the heart rates are fast or slow, they have the same chance of affecting the sodium channels. So a simplistic view of the classification is by looking at the Vaughan-Williams classification. So the Vaughan-Williams tried to classify these drugs based on the particular channel or the current that they block. So the class 2 and class 4 are beta blockers and calcium channel blockers respectively. We don't really think of them as antiarrhythmic drugs, but they are class 2 and class 3. The class 1 drugs, which are the sodium channel blockers, and class 3 drugs, the potassium channel blockers, are called the membrane active medications. So if you have sodium blockade, you are going to affect the phase 0. For the potassium blockade, you're going to affect the phase 3 of those action potential. Now, based on how the drugs bind with the channels, depending on how fast they associate and dissociate, and the effects on the ECG, they are divided into 1A, 1B, and 1C drugs. The action potential is not the same in all the regions of the heart. If you take the sinus node and the AV node, the phase 0 is absent because those tissues don't have the sodium channels. So the action potential in the pacemaker tissues is calcium dependent, and they also have like a steep phase 4. So once it reaches a threshold potential, it can start a new depolarization. When you look at the atrial action potential, there are some additional currents that are present in the atrium, IKUR and IKACH, which promote early repolarization, so the action potential is shorter in duration compared to the ventricle. Even at the ventricular level, the action potential is not the same in different regions of the heart. If you look at the epicardial cells, there's almost like a spike and a dome here. The mid-myocardial cells repolarize at longer periods, so you have a longer duration action potential. Now these changes, because of this heterogeneity, because of this epicardial changes, you can see that right bundle morphology in Brugada syndrome, early repolarization changes, or because of these differences in action potential in different regions of the ventricle. So when you give sodium channel blockade, the phase 0 changes, whereas repolarization remains the same. So QRS prolongs, but QT interval overall remains the same. That's for class 1C drugs. So class 1C drugs, depending on binding to the channels, they bind and dissociate slowly. So they are the most effective sodium channel blockers and the ones that we most commonly use in clinical practice, flecainide and propafenone. Now 1B drugs, the IV one is lidocaine, oral form is mexiletine. They have fast kinetics, meaning they bind and unbind so soon that you really don't see a whole lot of change on the action potential duration. So in fact, the QT interval may shorten with use of mexiletine and lidocaine. Now for 1A drugs, not only the sodium channel blockade happens, they also have an additional potassium channel blockade function. So they increase the QRS duration and they also increase the QT interval. And their binding characteristics are of intermediate kinetics. So quinidine, we use that in Brugada syndrome. Procainamide, in the boards, the question they can frame is WPW and atrial fibrillation. Diazopyramide can be tested in somebody with hypertrophic cardiomyopathy and atrial fibrillation. Compare that to the potassium channel blockers. With potassium channel blockers, the phase 0 remains the same, whereas the phase 3 is prolonged. And because of that, on the surface ECG, your QT interval is prolonged. Now, what is proarrhythmia? If you have a new arrhythmia, or if there is an increased burden of an existing arrhythmia after starting an antiarrhythmic drug, we refer to as proarrhythmia. And there are 3 distinct mechanisms for proarrhythmia associated with antiarrhythmic drugs. So the first one is you slow conduction so that circuitous loop can happen again and again and again. This happens with sodium channel blockade. So if you slow conduction, the arrhythmia can last longer. Now in patients with prolonged repolarization, prolonged QT, especially after potassium channel blockade, you can have oscillations of the membrane potential. We refer to them as early after depolarizations. So the early after depolarizations can start off a polymorphic tachycardia, which we refer to as torsades. Now the other arrhythmia is calcium overload. This is triggered and happens late after an action potential. So this is delayed, meaning happening after the action potential. You think of delayed after depolarization with digoxin and CPVT. Those are the 2 buzz terms associated with triggered activity delayed after depolarization. So let's look at scenario 1. So if you have an arrhythmia that can go around a non-excitable region, this could be either a scar or a functional region of block. So the arrhythmia is propagating, and in this particular patient, if you give a potassium channel blocker, you prolong the action potential and prolong refractoriness. Okay, so with prolonged repolarization, there is less excitable gap. And you can see there is not much tissue that is available to depolarize, and when there is no excitable gap, the arrhythmia terminates. So that's how the potassium channel blockers prolong refractoriness and terminate arrhythmia. Compare that with a sodium channel blockade. So if you give a sodium channel blocker somebody with slow conduction, you can make the conduction through the circuit slower, and the arrhythmia can last a lot longer period of time. Now this has been shown in the CAST trial, where flecainide was used to suppress PVCs in patients with structural heart disease, and those patients were dying because of ventricular arrhythmias. Now, the second concept for proarrhythmia with potassium channel blockers is prolongation of your repolarization. In this tracing, you can see the first beat is a sinus beat. You have a QRS followed by a PVC. The PVC conducts retrogradely, resets the sinus node, so it causes a sinus pause. The relative bradycardia prolongs the QT interval, and if you have an EAD, that can manifest as a PVC on the ECG, and again reset the sinus node, long pause. And now this time you may have enough QT prolongation to have series of EADs resulting in torsades. Now here is that animation. So if you have a single EAD, that you can see it as a PVC on the ECG. But if it is prolonged enough, and if you have a series of EADs, that results in torsades, polymorphic VT in the setting of long QT interval. Now this is shown in the SWORD trial. So SWORD trial is a trial which used sotalol, D-sotalol, which is an enantiomer, just had potassium channel blocking action without the beta blocker. So those patients had higher risk of mortality with pure potassium blocking drug. So in clinical practice, we use a combination of L-sotalol and D-sotalol. So the third mechanism for proarrhythmia is delayed after depolarization. So remember the letter D. If you have a buzzword digoxin, think about delayed after depolarization in the stem. So this is because of the calcium overload. The reason it's called delayed is it's happening after the action potential in phase 0. So if these little calcium sparks, either extracellular calcium coming inside the cell or little release of calcium from the sarcoplasmic reticulum into the cytoplasm, that can start off an action potential. CPVT is a hallmark arrhythmia of patients who have this delayed after depolarization. Now this is not pause dependent because this is happening in the phase 4 of the action potential. And this is the underlying mechanism when you see idiopathic VT, RVOT VT in your case stem. So for patients who have delayed after depolarization, isoprotenolol, pacing, exercise stress can actually increase that calcium sparks and increase the burden of arrhythmia. Now, digoxin toxicity, how does it cause increase in calcium overload in the cell? So normally you have a sodium-potassium ATPase cell, so where the sodium that got into the cell get pushed out in phase 4 in exchange for potassium. The digoxin blocks that sodium-potassium ATPase channel. And because of the extra sodium inside the cell, now the sodium-calcium exchanger is activated and the calcium gets into the cell, starting off that depolarization. Now, hypokalemia is one electrolyte abnormality that exacerbates the effects of digoxin on the sodium-potassium channel. With CPVT, the ryanodine receptors are abnormal. With that, you have a leakage of current, the calcium current from the sarcoplasmic reticulum into the cytoplasm. And there has been some recent evidence that flecainide may be able to stabilize these channels and prevent arrhythmias due to delayed after depolarization. So with digoxin, you should see a lot of abnormal automaticity. In certain patients, you see AV block. The AV block is because of increase in vagal tone when digoxin levels are high. Now let's go through a few questions. What is the mechanism of proarrhythmia in this particular patient? Have a look at this tracing. Look at the QT interval, this particular arrhythmia, and go ahead and vote on these 3 choices. All right, so prolonged repolarization and EAD, majority of you chose that. And okay, so calcium overload with DAD, a quarter of the audience. So when you look at this tracing, sinus rhythm, narrow QRS, and from here it looks like the QT is prolonged and you have a single PVC. So if you have a PVC that occurs on a T wave, the action potential has not completed and it is early after depolarization. It is not delayed, okay? And now you have another sinus beat with narrow QRS, PVC on the T wave, which is a EAD. If you have a long enough pause, that bradycardia causes more QT prolongation, and if you have multiple EADs, you have torsades. So the correct answer is prolonged repolarization with EAD. How about this tracing? So every other beat has a polarity of the QRS is different than the previous one. And this is one of the patterns that you should memorize for the boards. Great, great. So this is CPVT. Bidirectional VT occurs in digoxin toxicity and CPVT. It is delayed after depolarization, and the mechanism there is calcium overload. How about this rhythm strip here? This is an arrhythmia in somebody with structural heart disease. Okay, great. So structural heart disease, if you give patients flecainide, you can cause more reentry, increase mortality. So let's examine the states of concept of use and state dependency. Now the channels, the ion channels are not just open and closed, they go through series of states. They can be either resting, active state, or inactive state. And depending on the state they are in, the drugs may have particular affinity to a particular state. For example, if you have drugs that bind to activated or inactive, or open or inactivated state, they tend to have effects more at faster heart rates. If you have drugs that bind more with the resting heart rates, then like the potassium channel blockers, the effect predominates at bradycardia and not at faster heart rates. So the sodium channel blockers, 1C drugs, this is where the concept of use dependence comes. So the greatest effect is at faster heart rates, and it is because of this use dependence, they are the most successful drugs of termination of atrial fibrillation. However, the sodium channel blockers can convert fibrillation into an organized rhythm like flutter, as you can see in this tracing. And because of the slow flutter, now the flutter can conduct one-to-one to the ventricles. Not only that, you can see widening of the QRS at faster rates. So this is the use dependence, widening of the QRS, more sodium channel blockade at faster heart rate. And this is the reason why we try to do a stress test in somebody with flecainide. We would like to see how much of their QRS prolongs with flecainide with exercise. A key point here is if the QRS prolongation is more than 25%, consider stopping the medication in those particular patients. Now, another concept to remember for the boards is the state of the tissue. Generally, lidocaine and mexiletine are not effective in normally perfused tissue. If you have an ischemic myocardium, the sodium currents are depressed, and lidocaine has significant effect on an ischemic myocardium, and that is the reason we tend to use that in ischemic VT. And those patients are also at risk for toxicity. Remember that lidocaine is metabolized by the liver, and in patients who have a shock liver, they may not be able to metabolize the drug. The drug quickly accumulates and can result to toxic side effects. Now, reverse use dependency is a concept that we'd like to explore at rest at slower heart rates. There are two components of the potassium current, IKS and IKR. The drugs that we use, the potassium channel blockers, are IKR blockers. So you can see that there is more IKR contribution at rest, so we see more QT prolongation at rest. When the patients are tachycardic, IKS predominates, so if we give an IKR blocker, it has minimal effect on the rhythm. Now, this is a tracing where patient has a abnormal repolarization. The T wave is abnormal, and the potassium channel blockers are good for maintaining normal rhythm, but not for conversion. So, but keep in mind, avoid excessive bradycardia in patients with potassium channel blockers, because that can start a EAD and torsade in this patient. So in this particular patient, when he develops 2-to-1 AV block, the QT prolongs even more, and you have EAD resulting in torsades. So avoid bradycardia, long pauses in patients with potassium channel blockers. Now, amiodarone is one drug which blocks a lot of channels, so the chance of proarrhythmia is quite low. In fact, amiodarone can also lead to sinus node dysfunction in patients if you use it for a longer period of time. So to summarize, so the sodium channel blockers, they slow the conduction, and one of the proarrhythmic actions is they can promote reentry, can let that arrhythmia go for a longer period of time. They have this property of use dependency. They are very effective at faster heart rates. Potassium channel blockers, on the other hand, they act by prolonging repolarization. The proarrhythmia is if your QT is too long, you can have early after depolarization resulting in torsades. Remember, they're most effective at slower heart rates or the reverse use dependency. Now, the metabolism and interactions are something that can be tested. There won't be a lot of questions, but these are the questions whether you either know or you don't know the answer for these questions. So let's look at this question. So patient developed torsades after procainamide initiation. What is the likely cause? So either failure to acetylate to NAPA due to liver failure, or accumulation of NAPA due to liver failure, accumulation of N-acetyl procainamide due to renal failure, or you have attenuated class 1 effect due to SCN5A common variant. Okay, that's quite a spread there. So, that shows that we don't really use procainamide in clinical practice in day-to-day basis. So procainamide, this is one of those buzzwords that could be tested. So procainamide is mainly metabolized in the liver, and a part of procainamide is acetylated to N-acetyl procainamide, which is excreted by the kidneys. So the unique property of N-acetyl procainamide is it acts like a potassium channel blocker. So if you have renal failure, NAPA accumulates, the QT interval prolongs, you can have a EAD resulting in torsades. This is one of those words whether you know it or you do not know it. So drug elimination, so hepatic, you have the cytochrome P450 enzymes, you have the renal excretion. A lot of the drugs are excreted by the liver. Amiodarone, which can cause increase in LFTs. Lidocaine, remember in shock liver, if the hepatic blood flow is decreased, can quickly reach toxic levels. Verapamil, diltiazem, and propafenone. Flecainide has this mixed excretion, mostly by the liver, but some by the kidney. So you need to make some dose adjustment in patients who are end-stage renal failure. The potassium channel blockers, dofetilide and sotalol, are mostly excreted by the kidneys. Now, procainamide, remember the buzzword NAPA is going to be excreted by the kidneys. So here is a tracing, a potential question. So somebody who has a wide QRS and relative bradycardia. So you can see the QRS is quite wide, and you have almost like group beating here. So either a junctional or idioventricular rhythm followed by P waves, and eventually the P waves block. So propafenone is structurally similar to propanolol and has additional beta blocking properties. So there are these enzymes in the liver, the cytochrome P450. There are polymorphisms present in general population, and certain polymorphisms are associated with reduced metabolism of the drug, and you can tend to see side effects of propafenone, most commonly seen in African Americans and Asians. So the cytochrome 2D6 and 3,4A. If they're asking you about propafenone, remember this family, cytochrome P2D6 family. Now the cytochrome 3,4A, this family metabolizes several drugs. Notably, the ones that are important are amiodarone and dofetilide. There are several inhibitors that can increase the levels of the drug. There are inducers which can decrease the level of the drug and make it less useful. Now here is a question, potential scenario of drug interaction. A 50-year-old male with lung transplant was started on amiodarone for atrial fibrillation. What are the drug adjustments that you need to make in this patient? Increase warfarin, reduce tacrolimus, increase cyclosporin, increase digoxin dose. This is one of those trivia, whether you know it or you do not know it. All right, so that's the right answer actually. So amiodarone increases your warfarin levels, and in most patients you have to decrease your warfarin by about 50% long term. Now amiodarone also increases the digoxin levels. That's because of there is a P-glycoprotein mediated excretion in the kidneys. So the P-glycoprotein inhibition by amiodarone increases your digoxin levels. Now tacrolimus, amiodarone increases the tacrolimus levels, so you need to check a level and reduce the level. It doesn't really change the cyclosporin levels in the blood. On the other hand, cyclosporin can increase amiodarone levels. You may see more sinus bradycardia. So there's a lot of complex interaction. They're going to test you on common things. They're not going to go after rare trivia. So warfarin, amiodarone can increase your INR levels, digoxin, the tacrolimus. Cyclosporin, on the other hand, can increase the amio levels. A lot of drug interactions here. Good to know, especially somebody with a prolonged QT. Now, selecting the best drug for an individual patient. Now, the two main conditions that we use these antiarrhythmic drugs are atrial fibrillation and ventricular fibrillation. So the first thing, if you use a drug for atrial fibrillation, know whether the patient has structural heart disease or not. If there is no structural heart disease, all drugs are on the table. Dofetilide and amiodarone are usually second line. The best drugs are flecainide and propafenone. in patients who have who have hepatic problems, you can consider sotalol. If they have coronary artery disease, the first line medications are potassium channel blockers, dofetilide, and sotalol. And if they fail, go to amiodarone. Heart failure, only 2 medications. Sotalol is contraindicated. It's just amiodarone and dofetilide. So thinking about patients, it's good to anchor the particular drugs to a particular phenotype. So a typical class 1C patient is somebody who is highly symptomatic, young, who has paroxysmal atrial fibrillation, structurally normal heart. You can either use flecainide, propafenone pill in the pocket, or even as maintenance regimen. Now, class 3 drugs are somebody in an older patient who have symptomatic atrial fibrillation, some degree of LV dysfunction, coronary artery disease, but normal renal function. Compliance is going to be key. You cannot double up on the potassium channel blockers because that can lead to adverse arrhythmias. Now, when do you think of amiodarone? Amiodarone is somebody who is really sick, has significant kidney dysfunction, heart failure, and have failed other drugs. And if you want to maintain sinus rhythm, amiodarone may be the only option. How about ventricular arrhythmia? Again, the dichotomy is to decide whether somebody has structural heart disease or not. If they do not have, if they have structural heart disease, meaning EF low, coronary artery disease, presence of scar, look for the morphology of arrhythmia. If they have monomorphic VT, it's usually potassium channel blockers in combination with beta blockers. Avoid the 1C drugs, the flecainide and propafenone. Sometimes we combine mexiletine with the potassium channel drugs. Now, if they have acute ischemia, the presenting arrhythmia is going to be polymorphic VT. So fix the underlying ischemia, consider lidocaine. Remember, lidocaine is not effective in normal tissue. It's only effective if there is ischemia. And those patients, if they have bad reduced hepatic blood flow, are also at risk for hepatic toxicity. Now, if they have normal heart, this is our idiopathic VT. So monomorphic VT, it's idiopathic VT, fascicular VT. Consider beta blockers or calcium channel blockers. For fascicular VT, we talked about verapamil. That's the buzzword for fascicular VT. So polymorphic VT, these are the genetic syndromes that Mike Ackerman has talked about, long QT, Brugada, CPVT. Depending on the underlying genetic abnormality, beta blockers for long QT, flecainide to stabilize those calcium sparks for somebody with CPVT, and Brugada syndrome, you can consider quinidine. Quinidine affects that potassium current, reducing that spicum dome appearance. So once you start these medications, I won't ask you this, but I'll tell you an answer. So most of these potassium channel blockers, you have to choose the initial dose based on renal function and reduce the dose based on QT interval. The QT interval is more than 500 milliseconds, that's a usual cutoff, or JT interval more than 400 milliseconds, reduce the dose of the medication. What to do in terms of follow-up? So 1C drugs, make sure they don't have ischemic heart disease, get an ECG for baseline QRS, and a stress test to look for that widening of the QRS with exercise. For dofetilide, baseline QT interval, if it is more than 440, you cannot start dofetilide, ECG every 3 months. And you have to change the dose depending on the renal function. Again, for sotalol, baseline electrolytes, ECG based on the baseline QT interval, start the medication as an inpatient and monitor them on a regular basis. Amiodarone can affect a lot of systems, and I've given you a reference here. Regular follow-up is required to prevent side effects of amiodarone on a long-term basis. So I've included a lot of slides for your reference. This is more like a micromedics, but some of these concepts can be tested on the boards. It's good to review them right before, a day before your examination. So I think the key points here, So the antiarrhythmic drugs, remember that action potential. That's the key to remembering these antiarrhythmic drug classification. So there is a clear link between the mechanism of action and proarrhythmia associated with these medications. Know the concepts of use dependency. The sodium channel blockers are use-dependent medication. Potassium channel blockers are reverse use dependence. A lot of drug interactions, some of them can be tested, so review those reference materials. And selecting the right patients, and of course we do that on a day-to-day basis in clinical practice. A few guidelines for you to review, and I'd let Steve do the questions.
Yeah, those drug summaries are almost like flashcards, and I agree. The night before the test is probably a good time to do those. All right, so let's go over these questions. Which of the following is a characteristic of a class 3 agent? Slows conduction velocity with reverse use-dependent effects, prolongs refractory period with use-dependent effects, slows conduction with use-dependent effects, or prolongs refractory with reverse use-dependent effect.
Okay. I think the way to look at this question is try to break it down into two parts. So the potassium channel blockers are going to be affecting the T wave or your repolarization. So they affect your refractoriness. Second thing is the faster the heart rate, that repolarization is going to be shorter. Okay? So they're less effective at faster heart rate, so reverse use dependence.
And sodium channel agents affect the initial conduction velocity. Is that the?
So they affect the QRS, and they are they're more. If you look at that action potential at faster or slower heart rates, that phase 0 timing is constant.
Yep.
So even at faster rates, the sodium effects remain the same. That's why we call it use dependence.
Got it. All right. Question number 2 is, which of the following is effective for treatment of polymorphic VT occurring in the setting of triggered activity and delayed after depolarization? Isoproterenol, temporary pacing, calcium channel blocker or beta blocker, or sodium bicarb?
Okay, quite a spread there.
Yeah.
Key words in that question. First, they're already giving you triggered activity, okay, and delayed after depolarization. So it is happening in that phase 4 of the action potential. So pacing or giving medications that increase the heart rate, like isopril, increase those delayed after depolarization and actually increase the burden of arrhythmia. So these delayed after depolarization are RVOT-VT, CPVT, and digoxin toxicity. Now, sodium bicarbonate is only used in case of flecainide toxicity. We don't really use it for other arrhythmia conditions. So the answer that you're left with is calcium channel or beta blocker is the right answer. It reduces those calcium sparks. In an acute situation, adenosine does the same thing.
Okay. Question number 3. A patient develops symptomatic bradycardia immediately after starting propafenone. The mechanism is most likely which of the following? Sinus node dysfunction, slow metabolism due to a CYP3A4, rapid metabolism due to a CYP2D6, or increased levels of propafenone and 5-hydroxypropafenone due to the CYP2D6.
Okay. So this is one of those questions whether either you know it or you do not know it. So propafenone is metabolized by this CYP2D6 family of enzymes. And in patients who have a slow metabolizer phenotype, the drug accumulates, and you can see more QRS prolongation and more bradycardia. So this is something that a fact that you probably will need to know for the boards.
So the answer is D here. I think on the slide it suggested C on that display, but the correct answer is D in this case. All right, we have another question here, and that is, what is the most appropriate antiarrhythmic drug for a 57-year-old female with cirrhosis but no structural heart disease and normal renal function? You're treating atrial fibrillation. Flecainide, propafenone, amiodarone, quinidine, or sotalol.
Okay. So this question is mainly looking at the route of elimination of these drugs. So flecainide and propafenone is 100% by the liver. Flecainide, 70% by the liver, so predominant elimination by the liver. So you cannot use them in patients with cirrhosis. Amiodarone, it can affect the liver and cannot be used in somebody who has cirrhosis. Now, quinidine is also excreted through the liver. The only drug that's left is sotalol. In fact, in our syllabus, if you look, there's a med talk by my colleague, Dr. Garvin Kane, that goes through all these drug interactions in-depth explanation of the cytochrome P50 polymorphisms. And have a look at that talk. It's a great review of cardiovascular pharmacology.
Yeah, that's a good plug for that talk that Dr. Kane put together for basics of pharmacology. And there will be some questions on your test that have to do with drug-drug interactions and specifically relative to the antiarrhythmic drugs. It's going to be looking at interactions with transplant medications, statins, or probably the tube and anticoagulants. Since so many of those things occur together, you want to make sure you understand which ones affect one another.